Dr. Nitish, please start.
Good evening, respected teachers and colleagues. I'm Dr. Nitish Kumar, Cornea Fellow from Shankarai Hospital, Bengaluru. So I'll be continuing with my case presentation. So first of all, a 45-year-old male, an IT professional guy, working in Bengaluru, Karnataka, presented to our clinic on 18 December 2021. The chief complaints of diminished vision in both eyes, history of burning and drying sensation in both eyes. History of present illness. The patient gave history of diminished near vision in both eyes since 1 year, which was gradual, painless, progressive, and he's using near vision correction. A history of dryness and burning sensation in both eyes since 1 year, which increases as the day progresses and relieved by decreasing the screen time using artificial tears. It was associated with redness, foreign body sensation in both eyes. There was no associated itching, eye rubbing, watering discharge, or no intolerance to ambient light. Past history. Patient gives history of similar symptoms for which he took artificial tears with some relief in the symptoms. 5 months back, there was consultation done and he was started on sodium hyaluronate 0.1% 3 times a day and eye ointment hydroxypropyl methyl cellulose, dextrin 70 and glycerin at bedtime in both eyes. But there was no relief in the symptoms. So coming to the personal history. So the patient gives a history of screen time of more than 8 hours a day, history of artificial tears on and off since the past 4 years. The associated history is there's no history of dry mouth, no difficulty in swallowing in dry food, no feeling of dryness while breathing, no history of skin disease, small joint pains, morning stiffness, backache or neck pain, no history of tingling, numbness in extremities, weight loss or excessive thirst. There's no history of allergy, food or drug, no history of smoking, alcohol consumption, and the patient is a non-veg diet. Coming to systemic history, there's no history of systemic illness like diabetes, hypertension, thyroid disease, and tuberculosis. No history of sexually transmitted disease. No history of bleeding or thrombotic events. Family history, there's no history of systemic illness in the family. No history of any ophthalmic treatment in the family. Coming to the general examination, patient was oriented in time, place, and person. Posture was erect. Blood pressure at the time of presentation was 114 by 72 millimeters of mercury. And the pulse rate was 82 beats per minute. ECG was within normal limits. And no visible skin lesions were seen, no joint deformities, no lymphadenopathy. Coming to the visual acuity, the uncorrected distant visual acuity was 6 by 6 in both eyes and n by 10 with the PR accurate. The best spectacle corrected visual acuity was plain on 6 both eyes, near addition of plus 1.25 to n by 6. And the present glass prescription was a near glass of plus 1 with n by 8 vision in both eyes. The non-contact tonometry was 16 and 14 millimeters respectively at the given time and date. Coming to the external examination, facial symmetry, external face, head posture, ocular alignment, and motility were within normal limits. There was no erythema seen on the face. Coming to the slit lamp examination, first coming to the lids and the lacrimal system. The lid margin puncta were well opposed to the globe. There were good expression of the meibomian gland secretion, which was slightly turbid in nature. The regurgitation on the pressure of the lacrimal area was negative. And then there was no lid margin vascularization and no lid lag or lag of thalamus. Coming to the slit lamp examination. So first coming to the conjunctiva, there was diffuse conjunctival congestion in the right eye, and the left eye was a milder side. The papilla was present in both upper and the lower tarsal conjunctiva. There were no conjunctival folds near the lid margin. Episcleral and the scleral examination, there was in the right eye, there was diffuse episcleral congestion, and there was no thinning or uveal show in both the eyes. So coming to the corneal examination, the appearance was normal size and shape. On the surface, in both eyes, it was lustreless and tear film debris was present. The tear meniscus height was approximately 0.1 millimeters. Sensations were normal in all quadrants, and the limbus, there was uniform distribution of palisade support. Coming to the staining, first the fluorescence staining, there were diffuse punctal epithelial erosions in the palpebral aperture. As you can see on the right eye, diffuse PEs are present right throughout the interpalpebral aperture, spreading the upper 1 to 2 millimeters. In the left eye, inferior punctate epithelial erosions were there, and the lissamine graining stain was negative in both eyes. You can see the left eye, the inferior part 1/3 was positive for PEs. So coming to the rest of the examination, anti-chamber iris pupillary examination, lens and anterior vitreous examination was within normal limits in the slit lamp. Coming to the fundus examination, vitreous and fundus were within normal limits. Coming to the Schirmer test one, that is at 5 minutes, then the right eye was 10 millimeters and the left eye was 12 millimeters. And the fluorescent tear breakup time in the right eye was 6 and in the left eye also it was 6. So we formed a diagnosis of both high stage 2 meibomian gland dysfunction, both high moderate accuracy deficient dry eye, both high presbyopia and computer vision syndrome. And the presence of both meibomian gland dysfunction and accuracy deficient dry eye can also be labeled as a mixed dry eye disease. Coming to the management, so first of all, the patient was recommended a general lifestyle modification, starting with maintaining good hydration, avoid high glycemic index foods, follow 20-20-20 rule, voluntary blinking with full lid closure, then avoid working in low humidity and dry environment, good body posture, including eye orientation relative to the computer screen, use eye protection during outdoor activities like cycling or driving. Coming to the medical management, the patient was already taking sodium alginate and HPMC eye ointment, and we started the patient on cyclosporin eye drop, 0.1% 2 times a day, and eye drop fluorometholone, 0.5%, 4 times a day in a weekly dripping fashion. And hot water lid fomentation and lid massage was also advised to the patient. So as you can see, there's a chart of the follow-ups, and there's after 2 weeks, after 1 month, 1.5 months, and 2.5 months. As you can see, in the first 2 weeks, the symptoms were improved, whereas after 1 month, there's slightly increase in the redness in the left eye, whereas after 1.5 months, the reduced turbidity was there, and in the first month, increased turbidity was there. So dexamethasone eye ointment was started, which was stopped after 2 weeks. And after 2.5 months, you can see the patient gave history of dry mouth, and this is associated with the worsening of staining in both the eyes and tear film height. So at this point of time, as you can see, we had done one more baseline lipid view here to rule out any meibomian gland dropout. So here you can see slightly tortuous meibomian glands are there. Lipid layer thickness in the right eye is 33 millimeters, whereas in the left eye it is approximately 100 nanometers. And the C factor was okay. So at this time, we decided a rheumatologist immunologist referral because of the waxing and waning course in the past 2.5 months. So according to the rheumatologist's report, he was diagnosed as polycythemia vera because of the hemoglobin of 19 gram%, and ANA antibody was positive, RA factor and anti-CCP was negative, anti-SSA and SSB was negative. Hematocrit was increased and uric acid was slightly increased. The other viral markers like SPS, AG, SCV, HAV were negative, and imaging studies like chest X-ray, echo, ultrasound abdomen, HRCT chest were within normal limits. So the rheumatologist only
Thyroid profile done?
Yes, ma'am.
Thyroid profile?
Yes, ma'am. Thyroid profile, it was done, ma'am, not mentioned. It was within normal limits, ma'am. So the patient was started on tablet colchicine because, and no immunosuppressive agents were started right now. Colchicine was given for gout and tablet rabeprazole, domperidone. Diclofenac and serratiopeptidase was started. Hematologist reports tablet aspirin was started because of high hemoglobin and plenty of fluids were recommended. And the hematologist also ruled out any history of obstructive sleep apnea, which can lead to polycythemia vera. So as you can see, after systemic evaluation, there was slight improvement. And again, in the next 6 months, you can see here the tail film height was it was less than 0.1 millimeters, and the redness also increased in both eyes. And the post staining characteristics, the Shermer's and the fluorescein also, they were markedly worsened. So as you can see the photographs from the January 2023 follow-up, as you can see the diffuse episcleral congestion is there in both the eyes, and the luster is relatively maintained. The fluorescent stain, as you can see here, the inferior part, multiple punctate epithelial erosions are there, more present on the inferior 1/3, and some present scattered in the middle 1/3 also. Whereas in the left eye also, you can see it is present in the inferior 1/3 of the eye. So we decided the patient for punctal plugs. And after the punctal plugs was inserted, so we can see after 2 weeks of punctal plugs was inserted, the Shermer had increased to 5 millimeters in both eyes, whereas the fluorescein and tear breaker time was immediate in both the eyes, and Lissaman green was negative in both the eyes. So these are the photos after punctal plugs, punctal occlusion. As you can see, the area of the punctal epithelial posities has decreased substantially as compared to the previous photographs. Here also slight, very fine tear film height can be observed. And here is the punctal plug. Whereas in the left eye, the same thing was seen, and the staining has improved in the left eye also, and you can see the tear film height. Yeah. So again, a rheumatology review was done, and the rheumatologist did a minor salivary gland biopsy, and the report showed a florid lymphocytic salvadenitis, the formation of lymphoid follicles with a focus score of 5.2. And the rheumatologist started the patient on tablet methotrexate, tablet folic acid, hydroxychloroquine, metformin because the HbA1c was around 7, and the colchicine was continued from the previous time. So this time he was started with the immunosuppressive therapy. So according to the ACR EULAR criteria, so this is the followed uh, criteria for diagnosing a primary Sjogren syndrome. As we can see in our report, the first criteria is met, that is the label salivary gland biopsy, which the score is of around 3. And in our case, the anti-SSA and RO antibody were negative. Ocular staining was more than 5 in our case, so 1 point was given. And the Sherman test on both eyes, it was less than 5. So according to this criteria, our patient has a score of more than 5, and he was labeled as a primary Sjogren syndrome with a polycythemia vera. So we had revised the diagnosis with a mixed triad disease, presbyopia, computer vision syndrome, and in the systemic involvement of polycythemia vera, gout, and diabetes mellitus type 2. And the mixed triad disease is secondary due to the primary Sjogren syndrome. So as you can see, another after following up the patient after 3 months of punctal occlusion, as we can see, again there is a diffuse episcleral inflammation in both the eyes. Also, the lissamin green was positive in the right eye, as you can see in the circle. So again, there was increase in the P's spread. Diffuse P's were there. Tear film height was 0. The Shermers were also decreased. So as you can see, there's a waxing and waning course of the patient even after the punctal plugs. So we had gone with another LipiView scan. Here we can see this is normal orientation of uh, the Mewvin gland, and there was no dropout observed, but slight improvement of the thickness was observed in the right eye. Previously it was 33 nanometers, now it is 58. Whereas in the left eye it is slightly worsened, which was 42 nanometers, and which previously it was 100 nanometers. So we had also done a OCT macula to rule out any hydroxychloroquine maculopathy, and it was within normal limits. So we had revised the treatment. So we had added eye drop polypropylene glycol, and systemic treatment was also modified by the rheumatologist, and the sodium hyaluronate eye ointment was also added. So patient, due to the vaccine in many course, the rheumatologist also gave the patient pneumococcal vaccine and influenza vaccine because if injection rituximab is planned, so there are high chances of respiratory tract infection. So in planning of the rituximab, these vaccines were given, but the patient was started first with the mycophenolate, mofetilin, and methotrexate was stopped, and rest of the medications were same. So basically, as you can see, this was the last follow-up, and the patient is maintaining a good vision in both the eyes and with fluctuating signs and symptoms even after changing the immunosuppressive therapy. So coming to the summary, as you can see, it is a very the course is there is multiple ups and downs in the signs and symptoms of the patients. So summary is, as the patient presented with initial complaints of screen-related dry eye symptoms, with the regular follow-ups, there was worsening noted, but after a period of 3 to 4 years, after the local ophthalmic complaints, he developed some systemic manifestation on rheumatology and hematology workup. Along with the ophthalmic findings, an autoimmune component was diagnosed. So both local and systemic management was revised on the basis of clinical features and response to the treatment.
Any autologous serum eye drops were tried in between?
No, ma'am, no autologous serum eye drops were tried. Because patient was, ma'am, maintaining a good visual acuity, but only there was, and this multiple ups and downs were there in the signs and symptoms. So we we went with only the topical therapy and the systemic immune therapy only.
I mean, at any course before the insertion of punctal plugs or in any stage, they were
Yes,
not
ma'am.
tried.
No, ma'am, no, we have not tried autologous. So coming to the case discussion. So Sjogren syndrome, as described by Dr. Henrik Sjogren from Sweden, it is an autoimmune disorder typically occurring in women, but in our case, it was like in a male sex, and the immune cells attack the exocrine gland. So it is divided into two parts, that is the primary or the secondary. And the primary, which occurs alone, also known as Zika syndrome, which has sometimes these antibodies are also positive, anti-SSA and SSB antibodies. Whereas in the secondary, there are other manifestations like SLE and scleroderma, rheumatoid arthritis. So this is a triad of this is a this is Sjogren syndrome. First is the keratoconjunctivitis sicca, that is the dry eyes. Second is the xerostomia, that is dry mouth, and third is the inflammatory arthritis. So what is Sicca syndrome? Sicca syndrome excludes the arthritis part, that is a systemic part. So only the dryness is there, that is a dry eye, dry vagina, chronic bronchitis, or dry mouth. So what is the exact cause? Some genetic factors are there, HLA linked factors are there, some environmental factors are there, like some viral factors like HBV, EBV viruses are there, HTLV virus are there, which are being researched, and they are thought to attack the lacrimal glands and the salivary glands. So what happens, the etiology is like that. The antigen, this is a dendritic cell. So here is the antigen. And there is a T cell is inappropriately activated, which leads to stimulation of the B cells, which causes an increase in the anti-nuclear antibodies, and which is the SSA and the SSB. So here, these are the cells of the lacrimal and the salivary gland. So due to the damage to these glands, so these nuclear components are excreted. So these components are acting like an antigen. So it is an autoantigen. That is, it is an autoimmune disease. These antigens are captured by the T cells, and which activate the B cells and which cause further inflammation. So after this, so this is another diagram which is showing, as you can see, the T cells here, and these are attacking the lacrimal and the salivary glands. It is causing fibrosis. So there's a decrease in uh, the acinar tissue in both the glands, and which causes decreased secretory cells. This is another diagram showing, as you can see, this lymphocytic infiltration is seen inside the acini of the glands, which leads to the fibrosis of the glands and acinar atrophy, and cytokines are there. So these are the glandular manifestations. We have already explained the lacrimal gland and the salivary gland. Then the other glands are affected is the parotid gland, nose and airways can be affected, and dryness of the skin and vagina can be there. So coming to the extraglandular manifestation, this comes in the secondary Sjogren syndrome. So this affect beyond the exocrine gland. So systemic symptoms can be fever, fatigue, myalgia, weight loss, lymphadenopathy, and joint involvement can be seen in 50% of the people in people with Sjogren's. Other conditions can be vascular conditions, Raynaud's phenomenon, lung problems like chronic cough, interstitial lung disease, renal involvement can be there, autoimmune thyroiditis, monoclonal gammopathies, and cryoglobulinemia. The Sjogren syndrome is also associated with the mucosa-associated lymphoid tissue lymphoma. And as you can see here, we had this labial salivary gland biopsy. There was an increase in the lymphocytic cell-adenitis, which was already documented in the patient. This is a table showing gross pathogenesis and the clinical findings. So coming to the management of Sjogren dry eye, as laid down in the literature. So first of all, we have to screen the patient. So what should we ask? So we should ask how often your eyes feel dryness, how much is the discomfort, and how much is it impacting your regular day-to-day activities, and We have to ask the patient, do you have any dry? If any of the question has yes, so we have to investigate further. So this is another criteria which was laid down by the rheumatology union here. So here we can see both dryness and dry mouth. We have to ask the patient any dry eyes, any history of tree substitutes, any dry mouth, and all this history we have to ask. So we have to differentiate from other causes of dry eye also, because in cases like head and neck radiation, hepatitis C infection, acquired immunodeficiency syndrome, and graft-versus-host disease, they can also cause a similar picture. They can be overlapping clinical features. So that's why we have to rule out all this in history and in examination. And because of the final common pathway is more or less same only, but the etiology is different. So this is again the classification criteria we had discussed earlier. So what are the goals of the therapy? So the most important is the relief of discomfort. Why is the patient coming again and again to the clinic? Because his feeling is the overall quality of life is being affected. Second is a provide us clear and smooth optical surface. As we all know, there are clear optical surface will lead to a better visual acuity and decrease in the symptoms. Second is a prevent structural damage to cornea. Fourth is a appropriate systemic evaluation and management, which we had done in our patient. Also, we have to explain the patient about the education awareness about close follow-up, both with the ophthalmologist and rheumatologist, the physician. So this is a table showing the preferred practice patterns laid down by the American Academy of Ophthalmology. So different, right, starting from the screening guidelines, the diagnostic tests. So various the guidelines are laid down, and coming to the treatment also. So various treatments are being discussed for this dry eyes in Sjogren syndrome. So this is a treatment algorithm. So it is divided into two parts. So first is the dry eye aqueous deficiency without meibomian gland disease. The second is dry eye aqueous deficiency with meibomian gland disease. So accordingly, there's a severity level as you can see here, type level 1, level 2, level 3, level 4. So first is the level 1, that is a very mild level. So here we can educate the patient and you can eliminate the systemic medication which is causing dryness. So here we can give normal topical treatment like artificial tear, gels and ointments. So our patient started at this level. So gradually he progressed to the level 2. So here different therapies are also there. So we had started the patient on cyclosporine. We had also given some pulse steroid in between for minor inflammation, and punctal plugs are also given. And then if the patient is not able to maintain the level 2, we come to the level 3. Here different options are there like topical autologous serum, contact lenses, permanent punctal occlusion. And the level 4, the systemic anti-inflammatory medication is here the rheumatologist opinion comes. And if there is any eyelid or problem in the lid surgery, so we can go through with the lid surgery also in order to maintain a smooth margin and a smooth optical surface and ocular surface. So how this is different when it is associated to meibomian gland disease. So extra thing is that we will recommend the patient about warm compresses and the lid massage. And in the level 2, we can tell the patient for topical azithromycin or oral doxycycline, and expression of meibomian glands can be done also. In the level 3, we can do this LipiFlow pulse thermal compression can be done, or probing of meibomian glands can be done. In the level 4, it is similar to the previous algorithm. So coming to the take-home message. So first is the dry eye disease is a multifactorial entity and requires a thorough local and systemic evaluation. Male sex is seldom affected and autoimmune diseases, but may present with a severe signs and symptoms. And we should have a low threshold for starting steroid-sparing therapy, and a multidisciplinary approach is required, that is rheumatology and hematology in our case, and symptomatic relief is of prime concern. So we have to also assess the quality of life of the patient. Thank you.
Of late, Trehalose is being recommended, no?
Yes, ma'am.
Did you try in this patient?
Yes, ma'am. The 0.1% sodium hydrogenate, ma'am, that salt also contained, ma'am, trehalose, ma'am.
It also has it.
Yes, ma'am. That salt, ma'am.
Good presentation, Dr. Nitesh.
Yes, sir. Thank you, sir.
Can you come to the beginning of the presentation?
Yes, sir.
Well managed case as well.
Yes, sir. Thank you. So,
So,
examination.
yeah, just come to the beginning. Yeah. So for the Sharmas, how do you check Sharmas? What I
So,
mean to
Sharma.
ask is with your lids closed or open?
So let's close, sir. Initially, it was open, but the new way, like you tell the patient to close the lid, sir.
Okay, correct. And in the
Examination.
suppose in this case, after the fourth or the fifth visit, you all have planned to refer the patient to a rheumatologist,
Yes, sir.
and the rheumatologist has initiated the entire series of investigations.
Yes.
But suppose you don't have instant, immediate access to rheumatologist, or you just want to save the patient's time.
Yes,
What
sir.
all blood investigations would you recommend the patient to undergo
So,
and then directly approach the rheumatologist?
so like according to our clinical features and history, like the patient initially didn't give any systemic history, sir. But after like afterwards, he gave a systemic history. So in that time, sir, basic investigation we can do as we know, like so first of all is the antibodies of SSA and SS. This Rho and La antibodies are there, ANA antibodies, and since we know that rheumatoid arthritis is very commonly associated, the most common connective tissue disorder associated with Sjogren's disease. So we can also ask for an RA factor and anti-CCP antibodies. Sir. Other things can be, sir, normal viral markers can be done, sir. That is the HPSAG, HCV, and HIV. And also ruling out sarcoidosis. So these are the most common diseases which are associated with, sir, which have a overlapping or association with Sjogren's, sir.
Correct. And also vitamin D, vitamin B12.
Yes, sir.
In your presentation, I didn't see any mention
Yes, sir.
of D or B12.
Yes, sir. We should do.
Vitamin D is commonly associated with surface inflammation, low
Yes,
levels
sir.
of vitamin D.
Yes, sir.
So that is something that you could probably initiate once you suspect that there could be some systemic role
Yes,
involved.
sir.
So
Yes,
that way the patient can directly go with the results to the rheumatologist and immediately start the
mm,
treatment and all.
yes, sir.
So in your fluorescence staining pattern,
Yes.
what stain, what grading system have you used?
So Oculus Sika scoring system, sir.
Okay,
Oculus surface staining score.
thicker scoring system.
Yes, sir.
And for the conjunctiva,
So conjunctiva, sir, it has both Sika scoring, sir. The conjunctival are so both temporal bulbar and nasal bulbar are by Lissaman green, so in the this Sika score, whereas the corneal is by the fluorescence staining, sir.
so can you kind of give a detail as to how to score for cornea and the conjunctiva?
Sir, like in according to the Sika score, sir, if you are the fluorescence staining, we have to count the dots, sir. Different scores are given for the Sika score 0, 1, 2, 3, 4, 0. If it is less than 9, then 9 to 18, more than 30, then more than 33, more than 40, so like that. The number of this spots are there on the cornea. And if presence of filaments are there, then we'll give extra score of +1. Then if presence of confluent this punctured epithelial erosions are there, then we'll all that is additional +1. So that is for the fluorescence staining. The second is the Lissaman green staining. So Lissaman green staining is it is we can check on the temporal and the bulbar conjunctiva. So there we can there we have to see how much staining is there. So more than 8 dots are there. So according to that, so that scoring is different, and if lid margin involvement is there or not. So for that also extra score is given. So we club both these scores and a total ocular surface in OSS score is there, sir. If it is more than 9, then sir, there are high chances of this dry eye disease, sir. So it's like that, sir.
apart from that, what other scoring systems are available?
So the first one was the originally described was the Van Westerveld scoring system, sir. That also took into the account of the Cornell's the staining. The second is the Oxford staining score, which has 5 grades, sir, depending on the involvement in the interpalpebral aperture. Uh, then according to the tier this Dew's tour scoring index, sir, like there also they have mentioned the Cornell staining more than 9 spots, and the Lissaman green staining also more than 6 or 7 spots, sir. So different stainings are sir, there.
And for your MGD, how have you graded the MGD? How have you
Sir,
evaluated
sir,
MGD?
MGD according to the latest guidelines, like which is the international workshop of MGD in 2011, sir. There they have given the staging of Meibomian gland diseases, sir, according with the symptomology and taking into the corneal, the staining of the cornea into account, sir. So it is divided into stage 1, 2, 3, 4, and plus disease, sir. Then stage 1, sir, it is a very mild staining. That is clear secretions are there, asymptomatic, no corneal staining is there. Stage 2, mild to slightly turbid or slightly cloudy secretions are there, and the patient is slightly symptomatic, and very fine, a very peripheral stainings are present in the cornea, which in stage 3, slightly turbid secretions are there, and the patient is symptomatic, and the corneal staining is also in the inferior part, peripheral part, can be seen. In the stage 4, that is a severe staining. It is difficult to express the central pressure, and it is like toothpaste like secretions can be seen, and the patient is very symptomatic. Also, central staining can be seen in the cornea. And in the last is stage 4, there is inspission is there, not able to express the glands, and even after applying a good amount of pressure, and patient is very symptomatic. And the plus is given when association of any other ocular surface disease is there. So it's like that, sir.
So
So,
these Meibomian glands, in which lid are they higher in number?
so in the upper lid, they are higher in numbers, sir, as compared to the lower lid.
Secondly, uh, do you where did you check? I mean, do you check the upper lid or the lower lid or
Sir,
what for
sir,
your
like for
reading?
expression, we have to press the central lower lid, sir, and we have to give adequate pressure on the central lower lid parts according to the guidelines in
Yeah,
order to check the expression.
you'll have to actually check both upper and lower
Yes,
as
sir,
well.
upper and lower. Yes, upper and lower.
Can we come back to your examination part before your, yeah, that part? Yeah, okay. Next one.
Yes,
And how else can you, how did you measure the TFH?
sir, tear film height, sir, we have to measure in at the 6 o'clock window, sir. Here, so we can see at 16x magnification of the microscope and decrease, and we have to decrease the intensity of the light should be on the slightly lower side on the microscope. And there, sir, we can see on the, sir, the inferior margin is the lid margin. The margin of the tear film height inferiorly is by the sharp posterior lid margin, and superiorly we can see it is just opposing the globe, sir. So there we can, with the graticule, we can measure it, sir,
How
which is present.
else can you,
Sir,
so that is on slit lamp. Any other ways
yes, sir.
of seeing TFH?
So other ways is using keratographs, their low coherence interferometry. It is based on that principle, and the light is also infrared light, sir, and it is which decreases the chances of reflex secretion also. So there we can, sir.
Similarly,
Yes, sir.
yeah, go on, go on.
So there we have to, after the capturing of the photos, we have to manually mark the central and the nasal and the temporal tear film height in the
Correct.
keratograph, sir.
And along with that, have you seen TB UT?
Yes, sir.
Have you mentioned what was the T?
So fluorescein tear breakup time I have mentioned, sir.
Yes. And any other way of measuring TBUT?
So TBUT, so first of all, it's two types. One is a non-invasive one and the invasive. So fluorescein is the invasive one, sir. The non-invasive one is more sensitive towards the dry eyes as compared to the fluorescein, sir. So non-invasive is ideally recommended by the DUS 2 classification, sir.
Yes. There's one question in the chat. What was the systemic comorbidity in this patient?
So systemic, initially, the patient didn't give any history of systemic illness. I have ruled out in the history.
Correct. This question is from the YouTube chat. So initially, there was no systemic history.
Yes, sir.
And subsequently, when the patient was on follow-up after 3 or 4 visits, when it started worsening,
Yes,
and
sir.
you all evaluated, then other systemic problems were picked up.
Yes, sir. So patient had a past history also, sir. Like since like many years, he was taking his on and off artificial tears. So that could be a indication at that time. It was only a very local presentation only. The patient didn't have like too much of symptoms. But gradually, as the patient progressed, so like after 3 to 4 years, the patient started developing more severity. So that track has to be kept, sir, in this patient. So one more thing
In,
which we can, yes, sir.
in terms of lubricating topical medications,
Yes, sir.
what are the options? See, you've used sodium hyaluronate, HPMC. What are the options do we have? What are the molecules?
So first of all, the depending upon the severity of the dry eye, sir. Like first of all, if the like initially when the it's on the milder side, so we can give normal like hydrogels like HPMC and CMC and the preservative should be the better ones, not the BAC. The different preservatives are there, puride preservatives, polyquads are there, which are less toxic to the ocular surface. So if we can start from there initially, and like if we have to follow up the patient, and depending upon the severity, if the corneal involvement is there or not, so we can prescribe the patient sodium hyaluronate. So patient was already using. So sodium hyaluronate is known for its epithelial healing properties and migration of the epithelial cells from the limbal, peripheral limbal cells. So and whereas ointment form is helpful because it will increase the this aqueous film layer, and also the breakup time will be increased. And these dextrin molecules, glycerin molecules, they increase the retention time because they can absorb the whatever tear fluid is there, and they can expand in size, and they have more retention. And also due to more viscosity, there is decreased clearance from the lacrimal puncta, so which will lead to increased retention, and they will also decrease the tear osmolarity. As we all know that if increase in the tear osmolarities, there is increase in the inflammatory pathway. So these are helping via that way, sir.
One question from the chat is there any role of preservative-free lubricants in this?
So preservative free is recommended in such severe disease, moderate to severe disease, but slight limitations are there. First of all, cost is a limitation. Second, like they have to be stored at a particular temperature. Then and they are available in singules, and like we have to use them like
Unions.
instantaneously. Yes, sir. Immune. Yes, sir. So and there are high chances of like infection, or if that cold chain is not maintained, they can turn bad. So these limitations are there, and also cost is a very big limitation.
Correct. One thing I noticed is that in the first visit itself, you diagnosed the patient with MGD. But what are the current treatment guidelines for MGD?
So basically, so it depends like on the examination, where is the like what are the symptoms of the patient, sir, and the objective and the subjective signs. So we had also done a this lippy view scan also. So there we were able to see the normal pattern and slight tortuosity was there. There was no dropout was there. And sir, we know so from the recent evidence in the literature that the lipid layer thickness is like does not correlate with the amount of gland dropout, sir. So a year back in 2023, there's like a good evidence is there, sir, in ocular surface journal that the limbal layer thickness does not correlate with the gland dropout, sir. So and the patient was also not giving so that this symptoms, sir. So that's why we had kept the patient on, sir, this warm compressions and lid massage only. But afterwards, as you can see in the in our examination, when that like the scores deteriorated, the tear breakup time deteriorated, sir. That time we had started a propylene glycol medication, sir.
And what else would you give? Suppose the patient had a severe variant of MGD. What all will you give?
So we can go ahead with like a cystic. So first we have to rule out if there is any coexisting blepharitis. Is there any other infectious cause is there or not, sir? So that thing has to be ruled out, sir. And the what is this the patient's environment is there? What are the habits of the patient, sir? As we all know, our patient is there's an increased computer screen time is there, so which is directly related with the decrease in the blink rate. And due to decrease in the blink rate, there's a decreased expression of the meibomian gland secretions. So first, these things should be ruled out. So then secondly, if the patient is not even settling with the eye drops and the general measures, so then we can come to a systemic therapy. Systemic therapy includes a topical azithromycin and a topical doxycycline. So basically they work by inhibiting the lipases, which are the abnormal lipids which are there, which are produced in due to the inflammation. So they inhibit them, and also we can, if some infectious causes are there, so we can give the appropriate medications for them. So like we have to come to the systemic sides also.
In that, you can also give oral azithromycin, and
Yes, sir,
nowadays
oral.
the
Yes,
very recent ones also recommend that you can possibly give 500 mg once a day for 5 days. Then,
yes, sir.
along with that, topical azithromycin ointments and all 1% is available.
Yes, sir.
And many patients may not be uh, tolerant to doxycycline also.
Yes, sir.
So that's also one issue.
Yes.
Madhuri madam, from your
Yes. At what stage of treatment do you recommend the punctal plugs?
Ma'am, on maximum, so topical therapy also the patient was like deteriorating. Like we had also the patient was already started on cyclosporin also, and even after giving pulse steroid also the patient the tear film height was less than 0.1, and also the staining worsened. So at that time, we decided to do a separate plug, ma'am.
Which puncta you occlude?
Maybe occlude both the punctas, ma'am,
Both
inferior
of
and the
them.
superior punctas.
And with the immunosuppressives,
in this
how frequent do you monitor the blood counts?
Ma'am, like we were in a close association with the rheumatologist, ma'am, and the hematologist. So, ma'am, the patient was following up every 2 to 3 months with the rheumatologist, ma'am. So, that was being managed there, ma'am. So, uh, so that systemic component was taken care of, ma'am. We were only treating the local part and along with the support of the rheumatologist and the hematologist, ma'am. So that was a treatment.
in this computer vision syndrome, generally, whenever the patient comes, I'm not talking about this particular case per se, but what all do you counsel the patient?
Sir, first of all, we have to ask, what is the lifestyle of the patient, where he is working, the computer vision syndrome. what is the environment of the patient. So usually, like patients who are working in an IT sector, they have a like air conditioned rooms are there where there is low humidity is there. So this overall increases the like decreases the room temperature. Then second is the amount of screen time. What type of screen work is there? Some people require regular attention, regular, like they are doing some intensive tasks. So there is a substantial decrease in the blink rate. So we have to ask what type of work the patient is doing. Then thirdly, then like what is the patient rest time? Is he taking the adequate rest or in between the screen time, and what precautions he is following? And like what is the posture of the patient? Sometimes the screen is slightly located on the upward direction, which leads to the increase in the palpebral aperture, which leads to a more rapid evaporation of tears. Then uh, these things are there. Then so these are the basic things that we'll
Basically,
inquire about.
we tell also basically environment modification or environment management in the sense
Yes,
the AC vents and all or directly should not be coming directly to their face.
yes, sir.
Secondly, about the screen and the chair and the height and the angle of the screen. So those are
Yes, sir.
ergonomic factors that they need
Yes.
to take care of. And thirdly, about when we say that you have to take a break every 20 minutes, let's say,
Mhm.
although practically that may or may not be possible for a lot of people,
Possible.
but at least worst case scenario, you take one break every 1 hour. And
Yes,
what do
sir.
you do in that break exactly?
So
So either
basically,
you
yes,
look somewhere far outside the window and all for about couple of minutes, or else you just close your eyes and relax.
sir,
So
like
that's
it
what.
is recommended that first of all, the patient should look at a distance object, sir, instead of
Correct.
looking like shifting from the screen towards our smartphones, sir. Also, like blinking should voluntarily blinking with full lid closure should be motivated, sir. As we know, because this partial blinks are also associated with this computer vision syndrome, sir. So that should also be counseled. Also, adequate hydration should be maintained, sir. So in that period, so hydration can be, sir, like
And we
advised
have to
during
tell
that.
them about this subconscious decrease in blink rate. So once
Yes,
they
sir.
become aware of that, a lot of problems
Mm,
start settling down.
yes, sir.
And coming to your patient, once the systemic therapy and all that was started, I see that you all have also done, since the patient was on HCQ, you have also done an OCT for the patient,
Yes, sir.
right?
Yes, sir.
So, so for HCQ, if the patient is on HCQ, what
Yes,
all
sir.
do you investigate? One is the OCT, what all do you
Yes,
see?
sir. Second is the color vision we have to check, sir.
Correct.
Yes, sir.
Thirdly,
Sir, sir,
you could
like
just do
some side
fields as well.
effects. Yes, sir. Fields also. Yes, sir. Visual fields.
And what is the recommended schedule of evaluation for these patients who are on HCQ?
Second, I'm not aware about the
So
exact
basically, the
follow-up
risk
routine.
of it depends on two, three things. One is the dose of HCQ. So
Yes,
based
sir.
on the dose.
Yes, sir.
Secondly, in the first 5 years, it is quite low, the risk.
Mm,
Thirdly, after the fifth year, they need to get evaluated annually.
yes, sir.
Ideally, in most circumstances that we see, when the patient is first started on HCQ, the rheumatologists themselves initiate a
My
what
checkup.
do you say,
Yes, sir.
baseline investigation. So all those
Yes, sir.
baseline investigations are shared with the rheumatologist, and then
Mhm.
subsequently we are able to track the patient. So, and that is
Yes.
what is supposed to be communicated, and the patient has to be made aware of that as well.
Yes, sir.
Then a lot of things have been happening in your patient.
Yes, sir.
This
What
what
about the
punctal plugs do you?
gout?
Yeah, ma'am.
What's
Please.
that gout you have mentioned? He
Yes, ma'am. Ma'am,
has it.
ma'am, the cause of gout, ma'am, it is usually associated with ma'am polycythemia vera, ma'am, because due to increase in the breakdown of the hemoglobin, there is increase in the uric acid. So basically, it is secondary to this increase in the hemoglobin or the PCV, this gout, ma'am.
And which biopsy is recommended to? What is the gold standard for Sjogren's?
So, sir, biopsies are minor salivary glands, sir. Labial salivary glands can be taken, sir, like for biopsies, sir. The lip labial glands.
And this thing, when we encounter these patients, we'll have to tell them very clearly that we may not entirely be able to cure them,
Yes, sir.
but our primary role is to be able to manage the current situation, prevent it from deterioration, and
Yes,
thirdly, to make the patient as comfortable as possible.
yes, sir.
Those are the three primary objectives, and then would be the this thing. And for symptomatic improvement and improvement in the signs, which
Yes, sir.
medications have been proven useful?
So symptomatic, like sir, if corneal involvement is there, sir, so that time, sir, we are giving sodium hyaluronate is there, sir. So because if corneal involvement increases, sir, which so that can lead to like more chances of sir photophobia, sir, which can severely affect the lifestyle of the patient, sir. So we have to take care if this corneal staining is increasing, sir. That's why, we had started the patient on both topical as well as ointment-based sodium hyaluronate and trehalose, sir.
Actually, what
Salt,
I
sir.
meant to
Ach-
discuss was the role of cyclosporin actually.
Yes, sir.
The
Yes,
use
sir.
of
Cyclosporin.
cyclosporin and long-term use of cyclosporin
Yes,
is known to improve Shermer scores.
yes, sir.
Okay. And tacrolimus also could be given, but
Yes, sir.
obviously, the problem with tacrolimus ointment is that a lot of patients may be intolerant to it,
Yes,
and
sir.
especially when the ocular surface, if in very severe cases, when there is a lot of inflammation going on in
Yes,
the
sir.
patient. Although it is an anti-inflammatory, but it can cause a lot of problems. So when you initiate tacrolimus for any patient, you have to warn the patient that this ointment you may turn out intolerant to this ointment, but unless you try it on, we may not know. And you
Yes,
have to tell them that suppose you start tacrolimus, apply some at night. For the next couple of days, you might have stinging, burning, redness, and all that. But
mm,
persist using it for at least 7 to 10 days, and you will become tolerant to it. Quite a
yes,
few patients, after being made aware of this situation, will come back for follow-up and tell you that, yeah, initially it was a problem, and then they persisted using it and it was fine. So that is also there. I also see that later on you shifted the patient to cyclosporin 0.9%.
yes, sir.
So that is the preservative-free unim that you are referring to, is that?
Yes, sir. The nanomissile base, sir.
To be
Mhm.
refrigerated.
Yes, ma'am. It has been kept between 2 to 8 degrees Celsius, sir.
So how do you advise the patient? How should they use that
Sir, yes, sir. So
unim?
basically, sir, it comes in unim, sir. So we have to use when we open that unim, sir, we have to use at that time only and discard that unim, particular unim, and it should be used twice daily, sir.
Ideally, that is the most ideal scenario, but they are
Yes, sir.
quite costly.
Yes, sir.
So those unims, if you count the drops, they can give up to 8 drops. So
Yes,
suppose both eyes. So morning you apply 2 drops, evening you apply 2 drops. Okay. Some
yes, sir.
patients have also used it for 2 days. So basically 8 drops.
Yes,
And they've
okay.
been able to. But as long as hygiene, refrigeration, all
Yes,
that
sir.
is maintained, it is fine. But otherwise, if it gets contaminated, obviously it's a mess.
Yes. Yes.
And do you do Lisamin green stain for every case?
Yes, ma'am. In our ocular surface clinic, ma'am, Lissaman green is being done for every patient.
And any role of rose Bengal stain?
Ma'am, Rose Bengal is also there, ma'am. It is, but ma'am, the main problem with Rose Bengal is, ma'am, is the severe stinging sensation, ma'am. So, initially it was recommended that we have to use this with some people who are using some topical anesthetic and Rose Bengal, but again, we know the topical anesthetic will loosen up the epithelial barriers and it will increase the permeability. So that's why, ma'am, plus Lissamin green does not cause this stingy nature. So that's why we are preferring a Lissamin green.
What is the order of the workup you do in your clinic?
And first of
Suppose
all, ma'am, all the non-contact investigation, ma'am, we have to do, ma'am. Investigation is the examination, ma'am. So initially, in our clinic, ma'am, first we start with examination is done, ma'am, without touching the eyes, ma'am. Then first we do the Sharma one, ma'am. After doing the Sharma one, ma'am, ma'am will wait for some time, ma'am, for half an hour we'll wait approximately, ma'am, 25 to 30 minutes. Then after that, ma'am, first we'll do a ma'am lissamin green stain, ma'am, which is to be seen in a normal white light, ma'am. And afterwards we'll do this fluorescent stain breakup time. If any investigations are there of the this DPU, is there any keratographs, this investigations are. So for this, we usually call the patient on the next day, or we start with this investigation depending like what is advised, ma'am. So all these non-contact are done, ma'am, before all the contact procedures, because they can alter the results of other non-contact based test.
So, what is the difference between primary and secondary Sjogren's?
So primary Sjogren's, basically, sir, it does not involve the connective tissue disease. Basically, it has dry mouth, dry mouth is there, dry eyes is there, and chronic bronchitis are there. So all the linings which are secreting throughout the body, those are affected in the primary Sjogren syndrome, sir. But in primary Sjogren syndrome, only one systemic problem is that there is higher chances of MALT-associated lymphoma. So that has to be taken care of. Whereas in secondary Sjogren's, the connective tissue disorder, most common is the rheumatoid arthritis. Then is the SLE, then the scleroderma is there. So this is the basic difference between the two.
And for dry eye patients, do you do any questionnaires, or are you aware of any available questionnaires?
Yes, sir. According to the DUS2 reports, two questionnaires are there. What is the dry questionnaire 5, which has 5 questions, and the ocular surface diagnostic index is there, sir. So, but sir, like the questions that I mentioned, sir, here in the presentation, sir, we ask all those questions also, sir, in this patients, sir, this type of patients. So, like first is a dry mouth, then dry eyes is there, and difficulty in swallowing dry food. So that is a very particular thing, sir. Like we can ask the patient if he or she is able to like eat a biscuit without water, and
Correct.
so that is a very specific thing of this, sir. Otherwise, patients will give dry mouth also if they are not drinking water for like 3 to 4 hours.
Do
So
you basically ask them whether they need water to drink water to
yes,
swallow
sir.
foods commonly.
Yes,
So
yes, sir.
that was when, yeah. And okay. Anyways, for the benefit of our viewers, we will also be having our next grand round on 21st of June. That is after 2 weeks. Any other questions from our comments or chat box? So, Dr. Nitish, just to summarize it in very simple terms, suppose for a general, any ophthalmologist wants to start doing some dry eye workup, and they have
Yes, sir.
some common dry eye patient land up in their clinic. So, what are the bare minimum steps that you would ask them to do so as to do a decent dry eye workup?
So, first of all, basic history taking, like that is a very important thing. So, I've explained the basic, the more specific questions that we can ask patient, and those are the leading questions, and they can help in like this aiding the diagnosis. And then a thorough slit lamp examination is very important. The basic test which we are doing, so first is the
Specific, no, I mean dry eye specific tests or evaluations that they need to do.
so first
So the
we
first thing
have
you would
to,
ask them to obviously get the Sharmas done.
yes, sir.
Sharmas one that we say without anesthesia and with the lids closed.
Yes, sir.
Secondly, you would do a fluorescent staining. Okay. and you at the same of the cornea, you would check the tear breakup time as well. So that would be the third thing. Fourthly, you would do lissamine green staining of the conjunctiva. So these
Yes.
are immediately accessible things. Not
Exactly.
everyone may have access to NIT, but
Yes.
okay. So that's there.
Yes, sir.
And what are the how do you uh, and for of course the fifth thing would be to find out MGD,
Yes, sir.
lid related issues. So they might
Yes.
have to the very first thing be able to distinguish whether it is a aqueous related issue, evaporated related issue, or it is a mixed component. So
Yes, sir.
once they are able to figure out which component, which of these three variants it is, then they can proceed accordingly,
Yes, sir.
obviously.
Yes.
Dr. Madhuri, madam,
Yes, sir. It's okay. It's a good discussion that we had.
Yes, ma'am. Thank you, sir. Thank you, ma'am.
thank you. Thank you, Dr. Nitish. Thank you,
Yes, ma'am.
madam. Thank you, everyone who's been
Mm.
online for this rounds.
Thank you. We can leave.
Yes,
we?
let's
Yes,
close this
ma'am.
discussion. Okay,
Yes.
Yes.
Thank you.
well, good job.
Thank you very much. Thank you, ma'am.
Thank you.
Radhika.